Assalamu alaikum rahmatullahi wa barakatuh. Hello, Mrcog Part 3 Warriors. Warrior Mrcog support is back with something special. I'm Dr. Iman Bastawisi, and today we're going to talk about early ovarian aging. This topic has been discussed in 2 articles. First was released in 2019 and the second released in 2024. In this video, we're going to try to merge the information in the 2 talks. So for this video, we are going to start discussing first background about the topic, and then followed by discussing one of the Mrcog Part 3 exam question and how it's going to be easy to approach this question. So as usual, let's not waste your time. To understand the early ovarian aging, you need to know that it is a gradual process. It's a spectrum of accelerated decline in the ovarian reserve that usually occurs parallel or resembling the natural ovarian aging. However, it is accelerated and occurring in earlier age. This figure beautifully demonstrates how is the process of early ovarian aging looks parallel to the natural ovarian aging. However, it's occurring in earlier age. And it's important to know that usually oocyte number is lost more rapidly than the oocyte quality. It's suggested that the early onset of the ovarian aging may be due to smaller follicular pool at birth or to an increased rate of loss. Just to go rapidly through the normal ovarian aging. As you all know that each woman is born with a fixed number of primordial follicles. This is approximately between 1 to 2 million. And through the recruitment, development, selection for the ovulation or atresia, this process continues to cause decline in the follicular number. And at the age of menarche, the follicular number usually become between 300 to 400,000 follicle. And it's suggested that acceleration of the follicular loss occur around the age of 37, and this followed by the decline in the follicular number rapidly, where the menopause will occur when follicular number reach to 1,000. The cause of early ovarian aging is thought to be mainly genetic and epigenetic. So it's mainly involving the gene implicated in the DNA repair. Some other environmental factors, such as in utero endocrine and nutritional environment, environmental factors such as smoking, low socioeconomic state, obesity, endometriosis, and pelvic inflammatory disease. Well, at the molecular level, the talk article released in 2024 suggested some mechanism by which this disease is caused, such as the mitochondrial dysfunction, inflammation, oxidative stress, and telomere shortening. Now, speaking about the clinical implication of this condition, so this condition, as expected, will affect the fertility, where early loss of fertility will occur. So in early stages, the patient will show the ability to have natural conception, where no reduction in the fecundity rate, as the patient quality and quantity of the follicle is still within normal ranges. However, as the condition proceeds by time, fertility is going to be altered, and patient may appear as a patient with unexplained subfertility, who will be referred to the ART team, and she will show good response to ovarian stimulation with success rate following the IVF procedure and good outcome. Later on, with the quality of the follicle is impaired, then the patient will start to show poor response to ovarian stimulation and may experience some higher rate of miscarriages. Now, as again, by time, a decline or a marked decline in the quantity and the quality will occur, so the patient will appear in the gynecology clinic as patient with amenorrhea, secondary amenorrhea, more than 4 to 6 months, and by investigation, either premature ovarian insufficiency or early menopause will be diagnosed. This will be depending upon the age the patient will present. So before the age of 40, diagnosis of premature ovarian insufficiency will be the correct one. However, after 40, it's going to be, by definition, an early menopause. The patient needs to know that prediction of the age of menopause based on single ovarian reserve marker is not possible. Effect of this condition on general health for the patient? Well, as expected, the hormonal change associated with the premature ovarian insufficiency or early menopause will result in reduction in the life expectancy, and of course, the patient will be at high risk for cardiovascular disease, osteoporosis, and cognitive impairment. Diagnosis of early ovarian aging is challenging, and it will begin with risk assessment. So the age, the sexual history, obstetric history, as a patient may have previous pregnancy and good outcome. What contraception that the patient is using, which will affect the decision of the investigation that's going to be done for her. I'm going to discuss this in a while. Medical condition, to be specific more, if the patient has been exposed to any treatment for cancer. If also family history is a very good indicator for risk assessment, specifically if one of her like sisters or a mother or her mother has early menopause or premature ovarian insufficiency, this will increase the her risk for the condition. And of course, if she already undergone some fertility treatment, how was the response to ovarian stimulation? It's also going to be of benefit to screen for smoking and the social history. As we previously discussed, the low socioeconomic state is a risk factor for this condition. So the key test is basically, as you all know, is an ovarian reserve test. But the important point in this area, my friends, is that it should be serial assessment to track rate of the ovarian decline. So it's not just a single snapshot. So what are the common used tests? As you all know, this is the anti-mullerian hormone, which is the most sensitive for the quantity, antral follicle count, and the follicular stimulating hormone. Managing patient with early ovarian aging will differ according to the stage she presents with. So in term of the fertility, so the patient can, as we say, she can has natural conception in early stages. However, if a patient present with symptoms that are with subfertility and some having sufficient ovarian reserve, we need to investigate for other factors for subfertility. That's to say the semen analysis of her partner and the tubal patency test. If all investigations are within normal and she has sufficient ovarian reserve, then this patient can be suggested to have 6 months of trial of natural conception if she's ready to start her family. Now, if the patient is not ready to start her family, she should be counseled regarding oocyte cryopreservation or embryo cryopreservation. And this should be done preferably before the age of 35. However, well, honestly, my friends, if the patient is attending or appeared in the clinic in earlier age, it should be advised to encourage the process of oocyte cryopreservation as soon as possible, I would say. Now, the patient who attend with low ovarian reserve, usually the usual practice is going to be the in vitro fertilization. This is the most commonly employed treatment strategy for the women with low ovarian reserve. However, intrauterine insemination can be also offered for her with success rate of 15% per cycle. If the patient appears with extremely poor ovarian reserve, so oocyte donation can be discussed with this patient. The patient has to be counseled that the overall prognosis is good, especially if the patient appeared in early stages. And the exact or the most effective IVF regimen to be used is really unclear up till now. However, as in all patients going for in vitro fertilization, better outcomes usually occurs in younger women. It seems of benefit to use dihydroepiandrosterone for the patient with a low ovarian reserve who is going for IVF cycles. However, it seems that this increase the clinical pregnancy rate, the live birth rate, and the reduction in the miscarriage. However, as we discussed before, the clear regimen for the IVF treatment for these patients is not well established up till now. Some new techniques is being suggested by the new Mrcog article released in 2024. Some of them are at the stage of the animal study, some of them at the stage of the human study, and some of them has been released and been already used in real life. So these techniques will include follicular activation in vitro, stem cell therapy, ovarian tissue cryopreservation, platelet-rich plasma injection, and mitochondrial replacement. We're not going to discuss all these methods in details. However, knowing at least the topic of the new techniques is important for your exam. So in case if you are going for structured discussion, teaching, or presentation preparation, mentioning these techniques would be involved in the applied clinical knowledge. As I said, the first technique is a follicular activation in vitro. It's important to know that this technique had achieved 60% clinical pregnancy rate improvement and 18.4% live birth rate in patients with premature ovarian insufficiency. The stem cell therapy, again, the outcome is improvement in the ovarian function of 81.3%, and pregnancy rate is reached up to 29%. Platelet-rich plasma injection. This is a mechanism where the platelet-rich plasma is going to be injected into the ovarian tissue. However, it has some limitation and challenges as it is technically a bit difficult, and there is no standardization of the protocol for the preparation and the injection, the volume and the techniques, the area to be injected. So there is no standardization of the protocol. That's why the outcome is not very well established. However, it is reported to increase the pregnancy rate to 22%. The ovarian tissue cryopreservation, this is a used technique, and it's used to preserve the fertility in the pre-pubertal patient after cancer treatment. Typically, it involves freezing of the ovarian tissue and reimplantation after the treatment is being completed, and it has shown positive result in clinical settings. So this technique has been used, well established, used for the patient. So it's not only at the clinical trials. Unlike the artificial ovary, this is experimental and not yet applied in real treatment protocols. Mitochondrial replacement, yes, it still remain experimental and led to 6 live births, which is 21% up to date. Thinking about screening for the early ovarian aging, it's important to know that at present, it remains controversial with many barriers to outcome. And why is this? Because we have some challenging to screen for this condition. That's to say, the tool that we're using is the FSH, antral follicle count, and the AMH. For the FSH, we all know it significantly vary during the cycle, and it is a late marker, we would say, for the ovarian reserve with low sensitivity. The antral follicular count is relatively costly, and it has some inter-observer variability. The AMH is not stable through the menstrual cycle, affected by many biological, reproductive, and environmental characters, such as hormonal contraceptive methods and ethnicity. And most important, there is no cutoff value for which we were going to diagnose the condition. Now let's proceed with the one of the exam questions that appeared for the Mrcog Part 3, where you will be an ST5 who was asked to prepare a presentation to your junior colleagues on site for early ovarian aging. Now, after our discussion, I think that this is going to be an easy question for you. Let's start with the introduction. Usually for such type of question, we usually start with introduction, showing how important is this topic to be discussed. So early ovarian aging is often asymptomatic with preserved fertility. However, continued follicular depletion may lead to subfertility, menstrual disturbance, and early menopause. Prompt diagnosis allows timely management plan. So this is the importance of this topic, that the more or as soon as you are going to diagnose this condition, the more chance that this patient will have ability to take proper decisions upon her fertility plans, and can get best benefit and best results. So for the upcoming few sentences of the remaining part of the slide, I would say this is a template you can use for any presentation that you are going to prepare on site. So I will prepare my presentation to be engaging with positive vibes by keeping the light on for alertness. I'm going to include clear diagrams and interactive slides. I will encourage questions, offering evidence-based answers, and will seek feedback by the end of it. The content will be clear and simple, supported by relevant graphs, tablets from guidelines and recent articles, with essential links provided at the end This will include guidelines, talk articles, and related patient information leaflet that can be used while communication with the patient. So this is typically what we use to hear from our mentors regarding the teaching stations. So you need to keep the discussion between you and your colleagues interactive. You need to be to encourage questions to answer in an evidence-based strategy. You need to ask for feedback, and you need to give some materials for your colleague to go through it and to help them during their practice. So now we're going to proceed with the content of the presentation. I'm going to start with definition of the condition, and this is an accelerated version of the natural ovarian aging process, potentially leading to earlier natural menopause. I will be clear to inform my colleagues that this process resulting gradually in loss in both quantity, and later on quality of the ovarian follicles. I will stress that the early diagnosis for this condition allows for proactive planning. I will prepare one slide about the natural ovarian aging process, and I will discuss that each woman is going to be born by 1 to 2 million primordial follicle, and throughout their life, the process is going to lead to decline in the follicular number, and by the menarche, the number will be around 300 to 400,000. And at the age of menopause, usually the number will be around 1,000 remaining follicle. To make it easy for my colleague to understand how is the early ovarian aging follow a similar pattern of follicular loss as women with normal ovarian aging only occurring at an earlier age, I may share the diagram included in the TOG article published in 2019 about this topic. I will discuss with them through this diagram how is the stages this patient is going to present in our clinical practice, with early stages of normal menstrual cycles and normal fertility outcome, with time decline in the fertility ability is going to push her to attend in the subfertility clinic, where investigation may show an early stage of subfertility, and she can appear with unexplained subfertility referred to the artificial technology for the in vitro fertilization process. And in the beginning, she will show good response, later on poor response to ovarian stimulation, with recurrent miscarriage, and later on with premature ovarian insufficiency or early menopause. It's important also to share a table, include in the same article, that compare between the early ovarian aging and premature ovarian insufficiency. Early ovarian insufficiency is an asymptomatic precursor to early menopause, or at the extreme end of the ovarian aging spectrum, premature ovarian insufficiency. I will show them how is the difference between the prevalence between early ovarian aging and premature ovarian insufficiency, and how is the FSH will vary through the different stages in the early ovarian aging, and while in the premature ovarian insufficiency, the cutoff value for diagnosis is the 25 to 30 international unit per liter, and that HRT is not recommended in early ovarian aging patient except if she reached to the stage of the early ovarian insufficiency. I will discuss the possible etiological factor involving the genetic and epigenetic changes and the environmental factor with in vitro, in utero, endocrine, and nutritional environmental impairment, smoking, low socioeconomic state, obesity, endometriosis, and pelvic inflammatory disease. I will just enumerate some of the molecular mechanisms that caused the condition, such as mitochondrial dysfunction, inflammation, oxidative stress, and telomere shortening. I will discuss the clinical picture of this condition that will start with regular menstruation with known risk factor coming for counseling, subfertility, recurrent pregnancy loss, and premature ovarian insufficiency. A slide about the diagnosis, including the risk assessment, the key test that's going to be used, which is the AMH, antral follicle count, FSH. I'm going to be clear that ideally, these tests should be done in a serial assessment rather than a single snapshot tests. Management of this case, I'm going to discuss first to start with counseling the patient with proper education that this patient should avoid delay pregnancy, and fertility treatment option include egg or embryo freezing or treatment with donor sperm for single women. I'm going to counsel the patient to difficult prediction of decline in ovarian function and early to enter menopause, yet expect early menopause. I will be very clear to my colleagues that this patient may need to be referred to a counselor or psychotherapist, as the diagnosis may be traumatic for her. Giving patient information leaflet and guide her regarding the support group is crucial for her management. For the subfertility, to start with, the natural conception can be expected in young patient with reasonable ovarian reserve for 6 months. Patient not planning for pregnancy should be encouraged for oocyte cryopreservation best before the age of 35. And when referred to fertility clinic option, we may include IUI, IVF with her own egg or oocyte donation. Adoption also can be offered to her if she appeared in the stage of premature ovarian insufficiency. New techniques I'm going to discuss with my colleagues, just the topic, and specifically I'm going to inform them that both ovarian tissue cryopreservation and platelet-rich plasma injections are implemented for the time being, while other techniques are still at the stage of animal studies and human studies, that's to say the follicular activation in vitro, stem cell therapy, and mitochondrial replacement. For the long-term health management, I'm going to inform my colleagues that lifestyle modification to reduce cardiovascular and osteoporosis risk is crucial, and HRT is indicated when the patient appeared at the stage of premature ovarian insufficiency or early menopause. I will discuss prevention in terms of optimization of in utero environment and involvement of every and each culture institute, and to highlight the need for fertility education to be incorporated in schools. I will discuss also that screening for early ovarian aging at present, it remains controversial with many barriers to overcome. And thank you for your time. So by this, I hope the topic of the early ovarian aging is going to be simple for you if you face in the exam. We discussed today the topic in regarding the presentation preparation. This topic can appear in the exam as simulated patient task, as teaching station. So please practice every and each topic in different way of question, so you will be ready whenever you face in the exam. I was very happy to have this video for you. I hope this video is helpful, or it is going to help you in your exam preparation. Please, let's keep the conversation going. Your insights are important, and it matters a lot for me. Please drop a comment below this video and share your thoughts or questions. Also, please feel free to suggest any topics that you feel that is going to be helpful for us to discuss with you. And feel free to communicate with me on the number mentioned in this slide, on Telegram or in direct message. Thank you for your time.